Good evening, everyone. Well, I think we will get started. It's 6 p.m. And thank you very much for joining us for this Brainx Community live session for March 2021. I'm going to start off with some information about Brainx Community, as many of you are new to this platform that I can see. This started with a concept of having a platform for machine learning in healthcare for good, where clinicians, data scientists, and others could come together, share information, that is scientific information, and be able to collaborate. We have had 2+ very successful years, and our membership now has grown to 3,000+ international members, representing all different groups. A couple of websites that are listed over there, the brainxcommunity.com or brainxai.org. And we have a very active LinkedIn group where a lot of scientific material and opportunities to collaborate are shared. And of course, we have these monthly live sessions, and we went to Zoom even before COVID hit because there was a big demand from the international members to have something that was virtual. So we did that ahead of time. Here is what our website looks like. 3 sections over there: the Connect, the Data, and the Learn. And I'll go over those briefly. So Connect is where we have the repository of our prior events, some of the information over there, information about the speakers. So you can always visit that even if you missed the session. It provides you a link to the YouTube channel. So all these sessions are recorded, and if you miss it or you miss part of it, you can go there and watch through our YouTube channel. As I said, we have a very active LinkedIn group. So I would suggest, if you are on LinkedIn, or even if you are not, join LinkedIn and be a part of this and help share scientific information through this. The Learn section provides an area where we have links to some of the articles that might be relevant and pertinent to machine learning or AI in healthcare in general. We cannot provide articles themselves because of the copyright issues for majority part. So the links are there. You can go directly by clicking the link to their website of the journal, and they're categorized for the different specialties so that you can search those easily. And then we have one of the largest repositories of links to different data sets that are available for research. So as you can imagine, for machine learning, you'd need data. And there are quite a few open source data sets that are available, and the links are available through this, and more information about data and various approaches are also available through that. COVID-19, of course, represented a different and interesting challenge. So there is a specific area for COVID-19 data sets. And then we have expanded to Europe too. So there is a group that has been working actively in promoting our platform in Europe. And if you want to know about journals which are focused on scientific information and publications related to AI in healthcare or machine learning in healthcare, the links are available to you directly through our website. Here is an example of transcontinental collaboration, us working with engineering colleagues in India on certain COVID-19 topics and creating these models. And just recently, we're happy to announce that our colleagues, Dr. Ashish Khanna and one of the machine learning engineers, Alok Kothari, joined hands together in an excellent example of collaboration amongst data scientists and clinicians to launch a podcast series. So please subscribe to that, and you can listen to some very interesting conversations through Brainx Talks. We did publish our 2020 year in review just last month. And you can look at what is happening in different specialties through this. Of course, based on a particular methodology, it has certain limitations, some inclusion-exclusion criteria, but there you will find that even for psychiatry, the number of publications has been expanding year over year. And our specialist editor over there, who's going to be talking about it, Dr. Amit Anand, and Jungwon Cho were the ones who wrote about the review in this particular publication, talking about what they found were new scientific publications, or what are the topics and trends. And that's what Dr. Anand is going to talk to us more about later. We are very excited. This is the first time we are doing an event which is fully dedicated and focused on psychiatry. So we're hoping to foster collaboration and understand how psychiatry and behavioral science is leading this work. We're applying AI or machine learning to healthcare, very innovative and cutting edge. So we're going to have some excellent speakers with opening remarks by Dr. Don Malone. And with that, I'm going to actually transition over to Dr. Frank Papay to introduce Dr. Don Malone. Dr. Papay, who is the co-founder of Brainx and Brainx Community, is also the chair of Dermatology and Plastic Surgery Institute at the Cleveland Clinic, and has been very much of an innovator and has a great interest in AI applications in healthcare. He helped me form Brainx and Brainx Community, which has grown to be this amazing group. So, Dr. Papay, I'm going to transition to you for your comments.
Well, thank you very much, Piyush. And again, thanks, Dr. Handal, for contributing to these great lecture series. We're very excited to hear what's going on. It's funny today that we're talking about mental health and how AI and machine learning could assist and really help the access, the wide access, not only from patients to psychiatrists, but also patients to general practitioners that have issues in mental health. Just so happens today, my father's in the hospital, and I was sitting there visiting him, and of course I was watching my favorite show, C-SPAN, and they had mental health, and they had Congressman Kennedy in a group talking about the paucity of support by the government in mental health, which has been chronic in nature, and how things have changed because of COVID recently, and the fact they mentioned during this broadcast that there was a 4,000% increase in the utilization of telemedicine for mental health across all issues. And we can talk economically how that may change the landscape, and I can't wait to have our colleagues here discuss that. So without further ado, I'd like to introduce Dr. Malone. Dr. Malone is now the president of the Cleveland Clinic Hospital System. He's also a fellow alumni of mine from Northeast Ohio College of Medicine, and I'm proud of that. In addition, he was chairman of psychiatry at the Cleveland Clinic and also president of one of the hospitals of Cleveland Clinic, Lutheran Hospital. So he's going to make the introductory comments, and then we'll move on to the lecture. Don?
Hey, thanks, Frank. I appreciate you having me here tonight. It's an interesting day because just a couple of days ago, the Cleveland Clinic announced that we are now working with IBM, and IBM is going to be placing a quantum computer on the campus of the Cleveland Clinic. So we are extremely excited about that, and we believe that is will offer tremendous future research opportunities with psychiatry, and obviously brain being one of those areas that I think will be changed forever as things go forward in this regard. But as Frank said, I'm mostly an administrator now, and sort of I'm made to feel like I have artificial intelligence a lot of the time in my administrative roles. But it's my heart lies with the brain. My heart lies with psychiatry. My research was in deep brain stimulation, although I'm not doing much of that anymore. This is what excites me. It's kind of fun. I'm on a few DSMBs and I chair a few of those. And every time I get to spend an hour just talking about science, it's just so much fun. It's just so much different than what I do day to day. But we're very fortunate today to start with the person I know very well, Dr. Amit Anand. Amit's, is a professor and vice chair for research here at the Cleveland Clinic, and has done some really innovative work, certainly in neuroimaging, a lot of research with the bipolar patients in neuroimaging, as well as other studies. And he's the current national PI for a study looking at ketamine versus ECT in very refractory depression. And so we're very fortunate to have Amit. Thanks for coming tonight. And I don't not know Dr. Handal, but certainly I'm also looking very much forward to your presentation.
Okay, so thank you so much for the introduction, Dr. Malone. And yes, I met Dr. Mathur online and also talked to Dr. Papay. Enjoyed those talks very much. What we have to focus on now is on talking about how, in practical terms, algorithms can be built in terms of introducing psychiatry to AI and machine learning. So some of my disclosures are there. We basically developed our algorithms at Clinicom. And I supported that for many years doing research. As you can see, I have participated in many trials, and that's how we funded Clinicom, which is basically the company that has, or the software that has all these algorithms that I'll talk about. As mentioned before by Dr. Papay, healthcare definitely has been impacted by the pandemic, but in healthcare, mental health has been severely impacted. And we have had a threefold increase in patients' symptoms of depression and anxiety. And yes, telemedicine has been the way to go for now a year plus. We have been doing telemedicine and telehealth for a very long time as well. So in terms of, adults experiencing mental illness is close to 20%. And the problem is not just that there is 1.5 million people, according to the Mental Health America latest statistics, but we are experiencing a significant problem. Close to 10% of patients that are children and adolescents experiencing severe mental health problems. In general, it's sad, but many patients don't receive the care they need, and so important is to understand how can AI and machine learning help. So we have the other problem, which is that we need at least by 2025, we will need 15,000 more psychiatrists. And this is recent data as well. We will need 10,470 family therapies and almost 27,000 mental health counselors. So, excuse me, this need has been considered to be helped by artificial intelligence and machine learning. So in a recently published book in 2020, this was a global inquiry of what doctors, psychiatrists think in terms of AI and machine learning. The most important point here is that doctors think, psychiatrists think about 75% that documenting and updating their medical records is the most important thing in terms of getting help from AI and ML. So about 1 in 2 psychiatrists think that they probably will be helped by AI and ML, but there is a proportion of psychiatrists, especially in the US, and especially female psychiatrists that are a little bit more less enthusiastic about it, let's say. So we need to think about how do we introduce AI and machine learning into a medical algorithm. And in terms of doing that, we have to be very clear about what is this tool supposed to do compared to a gold standard. There has to be a very clear purpose. In addition, we have to identify what resources we have. Fundamentally, human, financial resources, research, what is the expected return? And one of the most important things, I think, in this strategy needs to be that the collaborative work between different individuals with deep domain experience, because you don't need to only be a psychiatrist to be able to help in a strategy like this. You have to be a psychiatrist open-minded and who has a perspective of technology that will help the purpose. So we have to think in a different way. So clinicians and researchers have to think that AI and ML is not just code. Doctors don't need to learn how to code. Excuse me. Doctors need to understand how AI ML would work and how it would help them. And on the other hand, engineers don't need to learn how medicine, they don't need to learn medicine, but they need to learn the medical logic. What are we going to accomplish? How are we going to accomplish that goal? And how is the tool or the device going to help the doctors? In addition to that, in the strategy, you have to have a leader who will be knowledgeable about the clinical goal, mainly the clinical goal, but also how the workflow will be improved and the utility and limitations of AI and ML. There has to be frequent and productive interaction between the engineers, clinical team, and the security, the researchers, and different pilot sites, because you will have to implement your strategy in different pilot projects that will test your device or your algorithms. All right. So what we need to think about also, so one of the most important things is that we need to understand what psychiatrists would need is that we have to understand what psychiatrists do. And this is a list of 10 tasks, the most important tasks that psychiatrists do. So some of those tasks are collecting patient information, gathering patient information, probably one of the very most important things that we have to do. Obviously, we have to prescribe medications, administer treatments, design a care plan, collaborate with other physicians and other clinicians, including counselors. We need to analyze our data, evaluate the results of our interventions, definitely labs and test count, but we have to advise. We have to advise the patients of what are we planning to do, how are we going to do it, what is the expected outcome. I see about 30 patients a day, and they're long days. And, I have to be able to explain my patients what I'm doing, obviously. And then the reports of our algorithms helps me tremendously in doing that. We need to analyze the treatment effectiveness of our interventions. And that is important also for understanding how AI has to work. And preparing a report is part of our business also. So many of these important tasks can be completed possibly with AI and machine learning. So algorithms in psychiatry have to include guidelines that we have. We have guidelines almost for every condition. The diagnostic criteria, including the DSM-5, standardized scale sometimes, research information that is recently published or published, in recent years, and some rules that we have to be mindful about. But the important thing is we need to link all this data to biological data, because in psychiatry, we talk about the biopsychosocial model. So the data has to be integrated with treatment data, stressors, military data, safety data, social data. In our algorithms, we even have developmental data. For instance, prenatal exposure to alcohol or drugs in the mother, etc. And these need to be written into an algorithm builder. So writing algorithms, you can write them on paper, and you can make very simple algorithms in a still mode using some software. But you need a real algorithm builder in which you can put your algorithms in and look at problem-solving procedures there. And that needs to facilitate the decision-making, and also we can learn from whatever outcomes we're looking at. So, excuse me. Algorithm builders can, like I said, you can write them on paper, and you have an example there on the screen on your left side. And you can put those algorithms into an algorithm builder. And hopefully it will be a dynamic algorithm builder that you can visualize, like you see the one on the right side. So this is an example of a suicide algorithm that we have in our product. And we took very seriously the impact of the psychosocial stressors that you see on the bottom in blue into how they impact the symptoms, the medical or clinical symptoms that you see in green. This intervention in linking algorithms is very complicated, and this is the reason why I guess over time, we have had sort of a slower progress in psychiatry than other specialties probably. So in general, these algorithms need, like I said, need an algorithm builder. And there is some inference that you can use. The Bayesian inference is something that we have been using that allows to combine prior information, about some population parameters with some evidence from the information contained in a sample. So that leads to being able to visualize dynamic algorithms and then have supervised machine learning. So basically, the clinicians and doctors that are using these algorithms can give you some feedback about something that didn't work out. You can fix the algorithm better in a supervised way, and then you have what some people call the rules-based suggested diagnosis. And then there is a key point here. We have to then, as clinicians using these algorithms, accept or reject the suggested diagnosis. If we accept and reject the suggested diagnosis, then that should go to a database. In our system, it goes to a database. Then the data is processed in the data processing system, and then that can generate artificial intelligence possibilities by knowledge-based diagnosing. If you add to that the tracking of previous diagnoses and improvement or no improvement of conditions, then your artificial intelligence algorithms start improving. But not everything is algorithms in order to create some tool that is efficient. There are many difficulties, and we have been doing this for, I think, 14 years. For instance, we have to create questions that are simple, easy to read, short, 8th grade level, 4 different types of answers that we have to consider. For instance, yes or no, or multiple choice, etc. And we have to think about different languages. For instance, our system is using now 4 languages, but that needs to be updated in our latest version, version 8. For instance, you have to think about if the patient will report for themselves, or if you have a child, it needs to be a parent or a grandmother, so a third party needs to be included. You have to think about variables based on age and sex. There are some questions you cannot ask for a 6-year-old or a 10-year-old, but you may need to ask for a 17-year-old. The questions have to be so that they are easy to use, easy to understand, intuitive, and then you have to balance all that, all these algorithms, the heaviness of all the questions, with the fact that you need to have all done by a patient in about 30 to 60 minutes. That's not easy also. It's very, very difficult to achieve that goal. So then you have to track and graph the results of your assessments. Then you have to think about security as well. Security, obviously, everybody knows is very important, especially in health and in mental health. Your device nowadays doesn't help at all. It doesn't help anybody if it's not mobile and different types of platforms. We're thinking a lot, obviously, in healthcare now, and for years now, about interoperability. And it sounds like things will get better in the near future. Integration is a real difficult task. No, it's made by ourselves, by big EHR companies, and that needs to get better. Then for research, we need the CFR Art 11. So your software needs to be compliant with that. We have worked hard, and ours is now. It needs to be clinically tested, and hopefully in a double-blind fashion. Ours has been tested with pilots for many years, and we are looking forward to do some double-blind studies. And then at the end of that, you have to have a report. You have to have a report that is available for the doctor, hopefully also not only on the screen, but also a report that can be converted in a PDF document. So I will show you a minute and 33 seconds of an algorithm in our algorithm builder. This is our real algorithm builder. You can see this is for insomnia, and then we're linking all these symptoms with in a container of symptoms, and then we're linking there the timing, and then some additional symptoms will be put in containers. And then you see there that we are trying to connect the symptoms with the frequency as seen there. And then we're connecting, for instance, if the patients have been suffering 3 months, it could be chronic insomnia. If they are suffering only 1 to 3 months, it could be recurrent, or it's episodic if it happens in 1 year a few times. And then how severe are the symptoms? And that's the container for that. So as you can see, this is just the insomnia algorithm, but it can be very difficult to build one. Now we can see an algorithm that was built by us that is a little bit more complicated. So this is the depression algorithm along with the suicide algorithm that correspond to that algorithm on paper that I showed you before, that we did initially on paper. So it is very, very large, so we cannot show one screen. And so that's just a view to be able to appreciate the work that has been done so far in our product. But now, what I wanted to see is I wanted to share a demo of actually algorithms that were built by us. And so this may take a second. Okay, this is a real patient. I'm sorry, a de-identified patient. But this is our report, and I was hoping to explain to you very quickly. I know we're out of time, but in this report you can see a few things. For instance, the severity of the depression and the suicide thoughts, and then you can change that as a doctor if you want to change it as a clinician. You can also see there if the doctor can accept, can reject, or can rule out the condition, and obviously, hopefully, that will be accurate. So one challenge we have is doctors accepting or rejecting very quickly without thinking very thoroughly and making a good decision. But hopefully that has to be done correctly. And then you can see the graph over time of different conditions. And you can select a color, and then that will match whatever condition you are following. And then this patient has had several follow-ups, you can see there. And then we can see a report by clicking. Let's see if we can get our report going.
And out with the demo site.
Okay, so there you go. So this is a full report. Most reports are very, very, very thorough and have, even we have narrations for every condition based on age and sex, etc. We automatically puts the name of the patient there. And if you scroll down a little bit, well, hang on 1 second, let's go up. You can see the medications, past medications, chief complaints, and biographical information. I think we're running out of time. Okay, let's go down a little bit. And then, for instance, in this patient, you can see their symptoms of ADHD. And well, let's leave it there. Okay. Okay. Are you going to go back to the report? To the report. Okay. All right. So you get the idea here. Where we can find whatever condition it pulled. For instance, a manic episode here. So you can pull different conditions there. In addition to that, if you send tracking, if you want to track your patient, you have automatically the suggested diagnoses will pull up so that you can add any of those suggested scales, or you can use standardized scales and add those for the follow-up. You can add DSM-5 questions. So the bottom line is this is very, very comprehensive. In my last slide, I want to emphasize that, in summary here, in closing, we need a lot of time to develop devices that will work, or software that will work, we need a lot of money, a lot of work, mental effort, a lot of talent, because creativity in developing these algorithms is really needed. And then, focus on leadership. Leadership and great focus is needed. Pilot testing, you cannot do this without pilot testing. We have about 50 pilot sites now that are testing. We have 94 algorithms that we have created already. And then we have suggested already 300,000 diagnoses. So we have been committed to doing this, and we have a great team with great collaboration, and I think that's what got us to this point. So that is the end. And if you have any questions, maybe we can leave it for the end, or we can do it now.
Yes, yeah, Dr. Handal, I think we'll leave the questions for the end. And thank you very much for demonstrating this too. And I'll request Dr. Amit Anand to have his slides shared. Dr. Anand, as Dr. Malone had mentioned, is the vice chair for research and in psychiatry in the Neurological Institute at the Cleveland Clinic. He is the winner of NIH grants, has been a prolific researcher all through his life. And for us, he has also been contributing to our yearly review, which is published in 2019 and 2020 with his specialist editorials. And he's going to help us talk, he'll talk to us about the topics and trends for AI in behavioral health and psychiatry. So thank you, Dr. Anand.
All right, thank you, Piyush. So I'm sorry, my computer has been giving me some trouble. I hope it doesn't freeze again. But how much time do I have? Hello?
Please take your time. Yeah, please take your 10, 15 minutes to give us a great overview. Thank you.
15 minutes, okay. All right, so I think, what I was going to present or where I'm coming from is slightly different from Dr. Handal. So I'm a researcher, a neuroscience researcher, a neuropharmacology researcher. So I'm not coming from the health delivery or clinical decision-making side. I'm coming more in terms of the pathophysiology of illness, the treatment aspects and treatment prediction, and long-term outcome prediction. So I just for this presentation, I try to write down why do we need AI in psychiatry. And for me, at least, and for a lot of us who do research, clinical research, and also practice of psychiatry, as you know, in psychiatry, there are no blood tests available. As yet, there's no radiology, neuroradiological procedures available. And so we really don't have anything to really inform our clinical care or treatment. It's just mostly done by clinical impression. And in research, the biological data available usually is difficult to collect and is very, very in small sample size. And up till now, we have been doing a lot of statistical analysis, which has only been able to provide group level results, but not individual level results, which is what we need in a clinical setting. So we don't have really, as I said, no particular lab test, no radiology test, but we do have a lot of behavior, lot of data in terms of behavior. And here it may be actually too much data. And a lot of interest in AI in psychiatry has been to actually to analyze this behavioral data, which can be collected in many ways. Smartphone is being used quite a lot. But here we may actually have more of a feast than a famine, that we have more data and we don't know what to actually do with it. And then, of course, there's a shortage of health professionals and lack of accessibility I think that Dr. Handal talked about that. So what I've been doing, or we've been doing, is basically trying to find biomarkers for diagnosis, for treatment prediction, for longer term outcomes in terms of relapses. Suicide is one very important one, which was touched upon, whether you can predict. Up till now, you may be very surprised to hear that those psychiatrists have been trying, are always, whenever a patient is suicidal, you send them to a psychiatrist, but psychiatrists are actually no good than anybody else to actually predict who's going to commit suicide. It's never been shown that psychiatric care has actually been able to prevent suicide as such. So suicide prediction would be a very big thing if we could actually get that. And then, of course, there are various other biomarkers, psychological biomarkers. And then, as I said, there are a lot of behavioral biomarkers that are being used. Smartphone data, actively versus passively collected speech is being collected a lot. The keyboard and analytics is being collected, and they can be used for assessing motor speed. And really, I mean, if you even have data from like 50 patients for 6 months, it's a huge data set. So in terms of research, on day-to-day research, this is what I said we are looking at, is exploring etiology, using large amounts of imaging, biological, genetics, and behavioral data, treatment effects and prediction of relapse, suicide, and illness outcomes. So I'm just going to give you a very quick example of a couple of things we have done. So one thing that I'm a mood disorders researcher, and we have got two types of mood disorders. This may not seem like a big problem to other specialties, but we have two types of mood disorders. One is bipolar disorder, the other is depression or unipolar depression. And the problem is that if a person comes with bipolar depression, when they are given antidepressants, which is what happens 90% of the time in a primary care setting, and even I would say in psychiatric settings, you are actually going to trigger, due to the use of antidepressant, a manic episode. And you would be actually, going against the Hippocratic oath that you're going to make the treatment worse than the disease. But you cannot clinically make out when somebody has come with depression, whether they are unipolar or bipolar, particularly in young people where there's not enough time. The time has not elapsed that a manic episode or symptoms of mania are evident. So one thing we have been doing is to figure out whether we can differentiate or classify people who are coming for depression as unipolar or bipolar. So one study, and this is just an example we did, was to actually, we collected smartphone data from depressed subjects with who are high risk for bipolar disorder because of family history or subthreshold symptoms, and the other ones who were low risk, and as well as young people who were diagnosed with bipolar disorder. And we collected smartphone data in terms of mood, in terms of activity, and sleep, appetite, those kind of things. And this was just for 6 months. As I said, this was a huge amount of data set. And we use hidden Markov models to classify states in these people. And we were able to classify the three groups quite well using the number of times a person's changed from what we call as a depressed state to a hyperactive state. And as you can see, the bipolar people had the most changes, the high risk for bipolar people had middle ones, and the low risk had the least. Similarly, we've been trying to use brain imaging to classify unipolar and bipolar depression, which is, as I said, a significant clinical problem. We've used fMRI data, in which in the fMRI, we give people a task to actually, it's called a go-no-go task, in which a person has to stop their response, and we give like emotional sort of stimuli, and they have to stop their response to like a happy stimulus or a sad stimulus, and you get some brain activation. And we've been using that to sort of classify. And as you can see, in different parts of the brain, you have activations, and there are some differences between the four groups. The bipolar group, the MDD plus is the high risk group with some bipolar symptoms. MDD minus is people who don't have any symptoms of bipolarity, and the healthy controls. And then we used machine learning to see whether we could actually classify people and find out differences. So we did find differences between bipolar patients and MDD with negative symptoms of bipolarity. But the most, what we were really interested with the right side to see whether we can classify MDD plus with MDD minus, major depression with subthreshold symptoms versus major depression with no subthreshold bipolar symptoms. And we had some moderate sort of a success in classify with about 70% accuracy. And then I think more recently, we have used what is called resting state connectivity, in which we actually get how the brain is connected. Functionally, we get like a pattern of brain connection, as you can see. So the brain is a very good, brain imaging, and the brain as such, whether you do EEG or other things, is a very good laboratory to test out machine learning, because we get lots of data in terms of connectivities, and it's a finite amount of data, and there's not much missing data. So you can actually do a lot of mathematical sort of analysis of that. And that's what a lot of people are doing. But the brain is a very complex organ. It is, I would say, still we don't know, how many things work, and it's a challenge. So we use this pattern of what is called resting state connectivity, and we actually recently submitted a paper in which we tried to classify the MDD versus MDD minus, and we had some success at about an area under the curve about 75. So I just want to give some examples. And then I think one other thing I just want to briefly touch upon is mental health delivery. So it was mentioned that there are less number of psychiatrists around and more patients. So certainly mental health delivery is a big thing. And it was one of the first AI kind of mental health delivery device was by a psychotherapist called Carl Rogers. He actually came up with a therapy in which all you have to do was it was not all you have to do, it was actually quite difficult to do. But whatever the patient said, the therapist was just going to repeat it or paraphrase it. So if a person says, well, I've been sad, and I don't want to go to work, and you say, well, okay, so it seems like, your mood has been unhappy, and, you're not being able to go to work. And this was very easy to actually, model in a computer. In the 1960s, it was done with a computer program called ELIZA. And actually, patients liked that computer program and would actually spend a lot of time talking to it. So there are more complicated versions now being developed, but you can deliver therapy using computers. And then smartphone analytics and recommendations is another big thing. Ginger.io is a firm in California now. I actually did that smartphone study with them first, but soon they realized that their platform was, they are not going to make money just by collecting data. And so they actually adapted it to provide treatment. And as they're saying, this is from their site, using tools backed by machine learning, the team of dedicated coaches, therapists, and psychiatrists identifies the most beneficial type of support and care for each individual. And you can go to their site and see what they do. And then, of course, the last one I said clinician accessibility and delivery. So I'll close by saying what, as a clinician as well as a researcher, what the limitations I see in AI. So one is, as Piyush said, for psychiatry, large training and test data sets are difficult to find. So, you may do a big study, but then if you want to divide that into a training and test data set, there's hardly any time that there are enough subjects. And really, from what all I have done up till now, the classification accuracy for anything is in the modest range of 0.65 to 0.70, sometimes probably 0.75, and it is not really enough for application and day-to-day clinical work. It has never been applied. So as people say, until somebody is willing to pay for something, it is not really, that's the ultimate, evidence that it is, it is something useful. I don't think any insurance company is going to pay for anything which is an accuracy range of 0.65 to 0.75. And certainly for things like suicidality, if you can only predict at like 70%, that is actually not going to do it. And then in research, as you know, there are lots of different machine learning methods and algorithms. And again, like with many other research, you can keep on analyzing the data in many different ways until you come up with something, you publish a paper, but replicability is is poor. And I don't think that is going to be accepted in a larger sort of setting. So data collection for us in some ways easy because we can get a lot of behavioral data, but analysis is difficult. And just because we are able to collect large data sets, or anybody, the good example is, the genetic GWAS studies. People thought that once we are able to get a full genome analysis, we'll know everything, and that has not really happened. So just collecting large data set, I don't think is, be all and end all of everything. And for clinical care, I think there's, of course, we are very far away. And actually, I've seen that lots of people may lose their professions, jobs, and particularly doctors are going to lose their jobs. I think radiologists are at the top of the list, but psychiatrists are nearly at the bottom because people think that psychiatrists are going to be not going to be replaced anytime soon. So I'll stop there. Thank you. And we can go on to questions.
Yeah, thank you, Dr. Anand. That was really impressive for both the speakers, Dr. Handal. You showed how end-to-end algorithm has been built, or rather multiple algorithms can be built and be deployed. I think it's a big challenge. So a lot of us who do research and all don't realize how hard it is to implement it. That implementation science in many ways is a bigger challenge, which looks like your group has overcome. So congratulations on that. I saw one question from Dr. Alok Kothari, who, or actually Alok Kothari is one of the machine learning scientists. He previously used to work for Apple, was involved with the Siri, which you use commonly. And his question was related to passive data collection. So Dr. Handal, if you want to address your thoughts on collecting it passively from data. Dr. Anand talked about use of smartphone and using some of the different kinetic methods to elicit how the patient is doing. Your thoughts on passive data collection?
Okay, so like everybody knows and everybody talked about, data collection is the key. So we can collect that data from the patients. And the way we collect data, obviously, is through smartphones and computers and tablets, whatever. The point is that what we are doing, collecting information from these patients, that is information, basically data that they report based on symptoms and psychosocial issues. That data eventually will need to be collected, will be linked to, for instance, other kinds of data. whether it's information related to movement, information related to temperature, information related to face recognition. There are several other modulators that need to be connected eventually to what we developed. And that's my thinking, and that's what we look forward to do in the future. So I think information has to be collected from many data points, different types of information coming in, and wearables, for instance. It is possible to link wearables to the data that we have, and so the sky is the limit in terms of how many sources of information we can link to get to the point where we know exactly what these patients are going through. I'll just give you one example. For instance, if we have a patient, okay, who is irritable, okay, and it can be difficult to diagnose that because patients with generalized anxiety can be irritable, patients with mania can be irritable, patients with insomnia can be irritable. So in our system, basically irritability goes, let's say, into the different algorithms, and you can have different diagnoses based on that irritability and other symptoms that go into the criteria. But if you could, for instance, check these patients' pulse, and define, okay, what are when are the times that this patient is getting very irritable? They could be triggers that the patient doesn't tell you, even when you interview them. And you can find out, okay, every time he gets home, at certain points, his pulse is going up. And every time he is late for work, his pulse is going up. So there may be different triggers that a lot of people would be thinking, gosh, this is what's triggering my irritability. So the bottom line is we have to at some point link our data, for instance, that we collect, which is basically clinical data, to data coming from other types of sources.
Dr. Anand, any thoughts from you? Dr. Anand, you might be on mute.
Sorry. So from my side, from my, can you hear me?
Yeah, with some echo though.
Yeah, I don't know how. Right.
Yeah, we can hear you now. I think the echo is gone.
Okay. Yeah, no, my thoughts are only this, that, the behavioral data that we can collect, I think it is just a huge amount of data. And unless and until you have, you are able to really analyze it really, really well, it is a bit of, it is, that is what my only point would be, as I said in the beginning, that psychiatry that way, for psychiatry, it is very seductive to use AI because you can collect a lot of behavioral data. It's easy to collect, but then what you do with it and what signal you can get from that is, I think still up in the air, at least from my side.
Got it. Now, it's interesting, you brought up two different points. Like, it's easy to collect a lot of data,
my comment would be.
Yeah, no, I think you bring up an interesting point that you can collect a lot of data, but still the data sharing is very limited, right? I've not seen any open source data sets. It still continues to be a very big challenge. Is that because of privacy issues? Is that because of financial issues? So for example, for imaging, there are a lot of open source chest X-ray data sets. For critical care, there are quite a few open source data sets. For dermatology, there are quite a few open source data sets. I've not seen any open source psychiatry data sets. So what's the challenge over there? Is it privacy concern? Is it financial? Is it just lacking a focus to develop that? What's the biggest challenge there?
Well, I think privacy is a big thing, and there are large data sets available. At least researchers among themselves are using them quite a lot. There's an Enigma consortium, which is, I think, for example, brain imaging, as you're saying, it is always, it is quite tricky to actually take a MRI, particularly structural MRI, and put it on a site somewhere, because to actually de-identify an MRI scan is quite difficult. And even if you are able to improve, to actually remove all PHI, if a person is able, there are ways that people can actually reconstruct your whole face. If a bit of the skin comes in, they can actually reconstruct your whole face. So people are generally a bit reluctant to openly, share data. Though I think within the researcher community, for example, NIH now has a national repository, and all, like for example, I'm doing an NIH study now. I have to deposit my images in real time on that server, and at some point it will become publicly available. So if you go to the NIMH repository of, it's called National Data Archive, I think all those results of many studies, including autism, mood disorders, schizophrenia, those things are available. I think the behavioral data sets, I think it will just be so big. I'm not sure where anybody, even for one site or one study, where they will put it.
Got it. Dr. Handal, your thoughts on that, on access to data?
Yeah, I agree. The optimal situation would be that we could have open data sources, but if I think about our own data, obviously I think about security, about patients' information security, which we came up with a very, very clever way of securing their information, but then you start thinking, if you do it privately, like we have done it, you worry about the investment you made and what is the goal. Our goal is to be able to provide this source in a way that helps as many people as possible. That's why we translate it into 5 languages. At the same time, we want to make sure that whatever the goal is, in our case, is making sure that a lot of patients in different countries can have this. But we have to complete our cycle in terms of our finances, because we have taken our own risk. We are at a different level right now. We have to be able to continue our operations in a secure way financially, as well as from protecting the data of the patients. And at some point, I think we will feel more comfortable in having an open source.
So, Piyush, may I just add something very quickly, which is, I think, relevant for psychiatry, is that, so one question which is, I think, issue has come up, that many of the lab specimens that are collected in the hospital, including genetic samples or other lab samples, once the patient has given the blood and it has gone out, who actually owns that information? And apparently, I didn't know that, but like it's in oncology, once the blood goes and for genetic analysis or something, it actually belongs to as long as it's de-identified, it belongs to the hospital, and they can sell it, they can do anything with that. Now, that is not the case with psychiatric information, that, when we don't have anything analogous to that, that if the person has told you something, you de-identify it, then you can sell it, So it's not like, psychiatry is not like Facebook. So, so that's, and that actually came up, I think Dr. Malone would know that we did have somebody who wanted to do something like that. And we said, we don't have consent until we take the consent from the patient. I don't think we can give you this information. They just want to do natural language processing and on the notes and just, then start selling that information. So
Yeah.
psychiatry things are different. Yeah, Don, yeah.
That was definitely not going to happen. Just a few comments. I think that, the day when we take some information and pull it through an algorithm and it just spits out a diagnosis, it is very far away. But I do think that AI can be highly relevant as a risk predictor. For example, one of the things we did at the clinic this year and is published is a COVID risk model. And we took all the information available in our electronic medical record for our COVID patients, and we were able to put together risk modeling for that individual, the likelihood they would end up in an ICU, or the likelihood that they would end up hospitalized or having long-term symptoms. And that risk could be 0% or it could be 80% or 90%. And I do see a day when you could combine diagnostic algorithms, biometrics, neuroimaging all together, and potentially have a risk modeling for something like bipolar disorder, that this person has a 90% risk of having bipolar disorder. Frank mentioned on here, facial expressions and voice. We did a study when we did DBS, on and off deep brain stimulation. When we were using that for depression, we actually looked at facial movements and predictive modeling of facial movements of whether these contacts would actually turn out to be a positive thing in this individual patient. It didn't really go very far, but you certainly can add things like that. And when you put that all together, I just wonder what you will find with regard to certain types of predictive modeling. That I think is a realistic thing. That I think is something that you could do within an electronic medical record in a given population of patients, and maybe find something positive. It wouldn't be definitive, but it could be helpful.
Yeah, great thoughts, Dr. Malone. I know we are beyond time, but I do want to take Dr. Papay's question and maybe have your comments first on this. Now being an administrator, how do you look at the value proposition of these algorithms? Like, what is it that you're looking at? I think his question was more related to time saving, as Dr. Handal had mentioned that 75% of time goes into documentation and all. So is that physician time saving as a value proposition, or as an senior leader, administrator? What are you looking at in defining the value proposition of these algorithms?
Yeah, I mean, I think that if there is going to be a time saving, it's going to be a clinician time savings, right? It's and potentially other clinician time savings. If we have patients that we'll see with functional disorders, if you will, psychosomatic disorders, that will go from clinician to clinician to clinician, and it may be, could you predict in that individual, and if you were able to make a diagnosis or predict a risk factor for something like that, you may be able to have both a time and a cost saving. But I don't know that there is a dramatic cost savings in putting together this machine learning algorithm for a single individual diagnosis. Again, a lot of what we know about how you arrive at these diagnoses is clinical. It's not biological, and until it becomes biological, until we're able to have some more definitive biological predictors, I think that it's still going to be a clinical diagnosis, which is going to take some time, regardless of how much is input you're still going to have that evaluation piece. And that does take some time. But I think if you can get some predictive modeling, as you begin to look at population health, you may be able to pull out the individuals that are at very high risk that you do want to address, so that you don't run into significant comorbidities or significant morbidity and mortality.
Great, thank you. Dr. Handal, what do you think? What are your thoughts on building the value proposition for these algorithms?
You know, the value proposition really is what is the utility of them. And, you know, predictive modeling is something extremely important, obviously. But the bottom line really is, are you going to build something with a value proposition that leads to psychiatrists, in this case, using your model, even if they individually agree to use it? You know, there is a whole process in which, you know, by which physicians adopt certain technologies, and it's not easy. That process itself is not easy. So, you know, I'm a big believer in creating possibilities and creating alternatives, using technology, using research in whatever way we can. But at the end of the day, the most important thing is the physician has to use it. It has to be easy. The patients have to be using it, and it should be very easy. We should back up everything with research. And at the end of the day, the bottom line is really we have to save some lives.
Yeah, great thoughts there. Dr. Anand, you showed some example of like multimodal you know, data use. So does that add to the value proposition, or how do you see that playing a part in value proposition when you build these algorithms?
Well, you know, I think, well, if you put enough data into a machine learning algorithm, you know, I think you will start getting some classification. I think I would like to actually talk to some mathematical expert in the machine learning methods. Why do we have this sort of you know, sound barrier at about, you know, 0.75, you know, accuracy of classification? There's something that you just can't get past that. You know, 0.75, 0.8 is difficult, but I mean, what we need in medicine is at least 0.9, you know, 90% accuracy or 95% accuracy for something to really be used in medicine. Though, you know, we are not able, even with, as Don is saying, with the COVID data, we get to 80% probability. But beyond that is very, very difficult to get at. I'm sure there's a mathematical sort of explanation for that. And I think the value proposition is, you know, probably going to be much more, at this time, I would say is much more for the health delivery system and for insurers than probably for the patient. You know, that I think these things can be used. And a lot of people, as they say, you know, 5% of patients, like everything else, 5% of patients are using probably 75% of the resources. And you can probably, if you can identify those 5% of patients, you can probably, you know, save a lot of resources, and the insurance companies are very much into that. So I think, so we have to think about is the value proposition we're talking about it for the patient or for the health delivery system?
Yeah, great thoughts. Well, I think I'm going to end at that. We are already beyond time, but thank you very much for joining us. Some great presentations, some great discussion. I hope everybody learned from this. If you missed part of this, it will be available on our YouTube channel soon. And hopefully you can join us for future sessions, listen to our podcast. All the content is available free to everyone.